So I'm Saffron and I'm Deputy Chief Executive here at NHS Providers, and I'm delighted to welcome you to this event today. Before we kick off, just want to say, just note that this session is being recorded so that those who weren't able to join today can access it, and so you also can go back and look at it yourselves. If you're not familiar with NHS Providers, we are the membership organisation for trusts and foundation trusts, and one of our roles is to help trusts deliver high quality patient care by enabling trusts to learn from each other, acting as their public voice, and helping to shape the system in which all trusts operate. This webinar today is part of our Health Inequalities programme, and it aims to support our members to make sense of health inequalities and embed health inequalities as part of core business. And we provide resources informed by our research and engagement with trust leaders, which have taken place over the past year. Can I have the next slide, please? So, our focus today, as I'm sure you know, is data. And what we're going to do is provide you with the opportunity to come together and discuss the challenges and opportunities around addressing health inequalities, but also to look at the role of data as a key enabler. We're going to explore two case studies from trusts who've developed data tools and dashboards to understand and monitor inequalities in patient outcomes. We're going to look at how data tools can be used to inform action in service design and delivery to reduce health inequalities. And critically, it will give everyone on the call an opportunity to share experiences and challenges of using data to inform their action on inequalities. We've got a great lineup of speakers today. So you will be hearing from Pippa Nightingale, who's Chief Executive of London North West University Healthcare NHS Trust, and James Biggin Lamin, who is Director of Strategy and Transformation at the same organisation. It's quite a long name, so I'm not going to repeat it. Piers Milner, who's Head of Strategy, also at London North West University. And then we've got Claudia de Vries, Health Inequalities Project Manager at Calderdale and Huddersfield, and she's joined by Rachel Westbourne, who's the Public Health Lead at Calderdale and Huddersfield. So we've got a great lineup of really experienced speakers in this area. Can I have the next slide, please? So a bit on the housekeeping. There's lots of detail there. Usual rules apply. I'm sure you're all familiar with doing these big online events now, but please, if you can, keep your cameras on. It's much nicer for other participants, and it's so much nicer for the chair and the speakers to be able to see who's on the call. But we totally understand when situations may arise that you need to go off camera, whether it's to take a call or another reason. So totally get that. If you lose connection, then please do rejoin using the link that you've had in the joining instructions. And in terms of how we will take this forward, if you want to ask a question, please use the raised hand function during the Q&A sections and we will bring you in. And really importantly, we won't get to everyone's questions today, but we will take those questions away and answer them after the event. I think it's really important that people know that. We will go through the questions, as many as possible, and to that aim, we will ask you to keep your questions and interventions brief. But I think it is really important that that people know their questions will be answered, and we will share the slides with you afterwards as well. So you don't need to be frantically either taking photos of the screen or scribbling those down, because you will have them along with the recording of the session. So I'm just going to, in the next couple of slides, can we move on to the next slide, please? In the next couple of slides, I'm just going to take you through some of our survey findings on health inequalities, just to provide a bit of context. So Today we're hearing from trusts who are using data really well to tackle health inequalities. But I think that what we do know is that accessing accurate, timely data is a crucial step in developing a robust response to inequalities. And it's an essential part of understanding how best to provide services that meet the needs of patients and communities that are more likely to experience marginalisation. So it's absolutely critical, as we know, that trusts are supported with data analysis and interpretation, resource, expertise, and capability so that they can embed a focus on inequalities. We surveyed trust leaders earlier this year, and we found that 85% of trusts are undertaking data analysis to better understand the populations they serve and to inform appropriate interventions and activity. However, a third of those responding also said that data availability can be a barrier to progressing action on health inequalities. And building on that, we know that there are some challenges to relating to data, whether that's data quality, such as ethnicity coding due to poor availability of other demographic factors, such as things like caring responsibilities. Data's often not joined up within trusts and across systems. Interoperability or a lack of it can really limit the understandings of population health. We know many trusts are implementing EPRs, but existing data infrastructure and less availability of resource and capacity within data teams can really limit the extent to which trusts can take an inequality lens to their data analysis. So trust leaders don't always have the skills, experience, or confidence to interpret and understand inequalities data to inform decision making. And without that really high quality, joined up data, the aspiration to really track, measure, and make evidence-based decisions to reduce health inequalities can't be realised. And we really do hope that the speakers we've got today will give you some insights into how you can take those really informed steps to improving your data quality. Can I have the next slide, please? So, what does good look like in this context? Our Health Inequalities Guide for board members on reducing health inequalities highlighted 4 areas that will help trusts to take a greater focus on addressing health inequalities. And these are leadership, enabling a strategic focus on inequalities, enhancing public health expertise, and taking a data-driven approach. And the guide provides a vision for what good looks like in each of these areas. And the data points are highlighted on this slide, and they include having data available by protected characteristics, implementing relevant training for staff, incorporating health inequalities into board reporting, and sharing data with system partners and monitoring data through accessible means, when things like data dashboards, so that you can see those improvements over time. And we will go on to explore in much more detail the notion of these data dashboards with our speakers today. And the guide also contains a specific set of objectives for trust boards that can be used to guide their work on health inequalities data. And we'll post the link to the guide in the chat and share it with the post event resources, so you've got that for yourselves as well. So I'm going to move on to the next slide, which is the first bit of asking you to do some work yourselves. So this is, oh, are we okay here? We've got a poll, I think, coming up now. So the poll question is, how confident are you in using data to inform your organisation's work on addressing health inequalities? And you just need to rate that, your confidence, out of 10. And 10 being extremely confident and 0 being not confident at all. So if I can ask you to do that now. I'm going to let that run just for a minute or so everyone has the opportunity both to think about how confident they feel and then to respond. Okay. Team, can you tell me where we're at on that? Because I can't actually see the poll.
Okay, yeah, so we've had 99 responses to the poll and it's really evenly mixed. I'll put a screenshot in the chat so everyone can see it, but we've got a real even spread with the biggest centered around the middle. So we've got about 15% who are feeling 5 on the confidence scale, and then 22 at 6 and 14% at 7. So really in that middle zone, Saffron, in terms of, I guess, neither confident or confident.
Okay, all feeling middlish. So great opportunities to learn from today and hopefully to push that up if we were, oh, great. Here, I've got the poll results here now. That's yes, very much in the middle. We've got a few 8s there. That's looking good. And 2% on 10, which is also great to know that there are some people really feeling like they're very confident on this one. So I think lots to learn and lots for us to share from each other. Okay, I'm going to move us on now, and I am going to introduce the first of the case studies that we've got. So the first one is the London and North West University Healthcare NHS Trust. And we've got, as I said earlier, we've got Pippa Nightingale, Chief Executive, James Biggin-Lamin, who's Director of Strategy and Transformation, and Piers Milner, Head of Strategy. And they're going to be giving us, as you can see from the slide, an overview of the Northwest London's health equity index and how they developed that and how it's they're using that to inform their work. So please kick off, Pippa and Colleen.
Thank you, Saffron. I'm Pippa Nightingale, Chief Exec of London North West. I'm going to give you an overview of the trust. I'm absolutely not going to give you the technicalities of how this tool works. I'll hand straight over to Piers and James for that. But I just thought it'd be helpful to start getting a context of the organisation and the environment that we're working in. So next slide, please. So London North West, who are we? So we're part of North West London, and the blue outline is the map of North West London. The two green hospitals in the middle make London North West. So that's our organisation. So we are based in the sort of northwest area of London. We've got the most diverse population. So we've got 3 boroughs, Brent, Harrow and Ealing. And between them 3 boroughs, we've got the most diverse population of any part of London. And as you'll see as we go through the slides, we are the most diverse organisation in England, which gives us some real challenges, but actually gives us some real exciting opportunities as well. We are an acute trust. In terms of size, we've got about £1 billion turnover, 10,000 staff, hospitals across 3 sites, which again is another great opportunity for us. I think my comms team have been very clever there. Believe me, they don't look that green and leafy. So I don't know how they've created that picture, but the one on the left is Northwick Park, which is our biggest site. It's got the biggest A&E department in London, the busiest A&E department in London. It's very much a acute hospital site. In the middle is Ealing, which is a DGH, fully functioning A&E, but a smaller hospital, but in a very deprived area of Ealing in Southall, which again is a different population, different community that we're providing healthcare for. And then the one on the right is Central Middlesex. It's a PFI, lovely new build. Feels like you're walking into an airport, which is great. Hasn't got an A&E, so it's a great elective site for us, but again, in a very deprived area of Brent. So there are 3 hospitals that we provide healthcare from. I think what I would say is, so the size of Northwest London, 2.3 million size population. Across the R3 Trust, we're providing healthcare for 1 million of that 2.3 million population. And we work as part of an acute provider collaborative. So there are 4 trusts within that. We've got in the blue to the left is Hillingdon Hospital. They've got a main site. It's a much smaller than the rest of our sites, and a cold site in Mount Vernon. Then you've got the pink, which is Imperial. So St Mary's, Western Eye, Queen Charlotte's, Hammersmith and Charing Cross. And then we've got Chelsea and Westminster at the bottom there in the purple. So Chelsea and Westminster and West Middlesex. So that we make collectively the acute provider collaborative in Northwest London. What I will say right now is we've gone through the pain that many of you might be going through or might have been through, but we are on one single digital platform. So we all share the same EPR. We're all on Cerner, and it's the same Cerner platform across the 4 trusts. So we can share records, we can share data, and that has taken us quite a long time. It's been a 15-year journey to get us all onto that platform, but just last year we all got onto the same platform. Which is where we are with the start of some of the great data things that we can do together. Next slide, please. So as I've alluded to, we are serving the most diverse population, which is fantastic. We've also got the most diverse staff group of any trust in England, which is also fantastic, actually, and really starts to give us some insights and understanding. It gives us a platform to have some great conversations. And actually, it gives us a really good infrastructure for staff to be able to challenge us and really try and really tackle some of the inequalities that we know we've got within workforces and within patient populations. And I mean, 72% of our staff are global majority staff, and many of them are local residents too. So many of our staff are our local population, which again has some real strengths in some of the work that you can really start to unpick in terms of the equity agenda. Next slide, please. So there will be no surprise to you that equality is a big part of our trust strategy. It's broken down into many layers, but actually equity runs through many of the strands of our strategy. So providing high quality care, probably not different to many organisational strategies. However, ours really does break down to some of the inequalities of the populations that we're providing healthcare to. We've got one of the biggest sickle cell populations in Brent. They have been very underserved, and COVID did not serve them well at all. So we've done a lot of work working in co-design with that population to really start to look at what does good healthcare look like to a sickle cell population. How can we provide the keeping well, the preventative arm of their care, but how can we also care for them safely during a sickle cell crisis? And that's a big part of the work that we're doing in our strategy. Maternity has got a very different dimension to us. So 82% of our women using our maternity services, so our birthing women and families, are from global majority populations, which again means that we have to provide services in a very different way. There are many language barriers. We know that the national figures around maternity are 4 times more likely to have a stillbirth if you're from a global majority background, and they are the populations that we are providing care for. So we've done lots of work around really trying to design our maternity services to meet the needs of our population. And then we've done some great quality equity work around pressure ulcers and skin tone. We absolutely know that preventing pressure ulcers in people with different coloured skin tones can be really challenging. And we've been the first trust to implement the skin tone pressure ulcer diagnostic tool, which has really reduced our pressure ulcers. So there's some great work that we can really start to do around quality and our equity lens. The other arm then is our staff force. So we have to work differently with our workforce. We know the challenges that a global majority workforce face. We know that when we look at the res data, people on an executive board generally look like me. They do not look like my population. They do not look like the majority of our staff workforce. So how do we change that clock? How do we really start to turn the dial and meaningfully progress people through their careers and removing barriers? And removing challenges that we know that exist in terms of progression in workforce. So we've done a lot of that by listening. We've got lots of staff equity groups that are really vibrant. They're all executive led. They've all got executive mentors. But we've done a lot of work really unpicking and doing deep dives into our res data and our medical res data. That I think the medical workforce actually, when you start to look at it, probably have more inequity than we do the normal wider workforce. So that was a really important part to unpick the details of that. We've done a lot of work around our policies. So in terms of recruitment, we've got a big piece of work around inclusion and recruitment and trying to break down the barriers, really moving to a more modern way of recruiting people. So everybody is given the questions in advance of an interview. So everybody's got fair opportunity to prepare equally. There will be no surprises at interview. It really starts to unlock some of the language barriers and challenges people have at interview stage. So we've really done some work around inclusive recruitment and around reducing people in formal disciplinary processes, and more of an early resolution piece that we've looked at there. And a big part of this is training. So we've got the progress 2 to 7. We know that when we look at our workforce, the biggest proportion of our staff work at band 6 and below, our global majority, and that completely flips when you go to a more senior end of our workforce. So how do we progress people through their career? And that's our band 2 to 7, our progress 8 work, our white allies, and our managers guide. So we've got some equity inclusive management training that's really started to make a difference into empowering managers to manage in a more fair and equitable way. And then we've got lots of celebrations. This is about talking. This is about breaking down boundaries. This is about, I've got a staff inclusion group that really challenge us as an executive group, but it's fantastic. It generates great conversation, great discussions. Some of the really difficult conversations are really starting to happen, which is great. And then we celebrate that. We've had EDI festivals. We've had a fantastic unity event when we had the civil unrest. It was really powerful, actually, to make sure that our staff felt supported and safe during then. And all of these processes that we had in place allowed us to do that. I'm now going to hand over to Piers, I think, to talk to you about the equity index, how we use it, and how it's really starting to change our practice.
It's me, actually. Hi, I'm James Wigan. I'm Director of Strategy and Transformation. I'm going to say Piers was saving for the most technical and the most clever stuff. We're here today in the workshop around how we use data to address health inequalities and equity. And the context of everything we've shared and all the work we've been doing, we wanted a way to understand how are the changes we're making, how will we know if they're an improvement? And that's the background to the equity index. When we published our strategy in 2023, we wanted a way of measuring how are we delivering in the same way we can on some of our clinical outcomes and our clinical performance and our staff performance around the equity of our services as well. And looking around, there wasn't an easy way of doing this. There are lots of comparisons you can make, but with so many different communities, so many different needs, we wanted something that brought it together. And that's where the equity index comes from. At its simplest, it is a number that goes between 0 and 1. So 0 on the left-hand side of the screen shows you a really equitable outcome where whatever group, everyone's getting equitable outcomes. On the right-hand side is a really inequitable outcome. And so when you score 1, you've got one group that's very, very advantaged, very, very privileged versus everybody else, and real gaps and real inequalities. And the way the equity index works is it allows us for any outcome, whether that's, and we're an acute provider, but this would work just as well in primary care and community and mental health, and even outside of healthcare, social care, education. This methodology would work to think about the equity within an outcomes metric, how it can consider a whole range of different factors, deprivation, race, but any other important characteristics, such as people are speaking English as a second language, around age, around learning disabilities. And it's been co-designed, and it created this with a diverse group of our staff, our patients and partners. What I'll say just before going to the next bit is what it isn't is it's not pointing us to a particular outcome. It is a way of measuring an outcome. It doesn't tell us we need to do a particular thing. So where you might have seen data used in the past suggest you need to move some patients up a waiting list for a more equitable outcome, it's not pointing towards that, but it would tell you if you went and tried and piloted an intervention such as that, is the outcome that then happens an improvement or not on the equity compared to today. Next slide, please. The reason why having a number is so important is because it allows us to make comparisons, and those comparisons help us understand if we're making improvements and how we can make further improvements. So first of all, it allows us to compare between outcomes, and we'll talk later about how we've used that to help prioritize where we're going to focus first, because we want to focus on the outcomes with the greatest inequity and make improvements there. It also helps us to understand what's happening within an outcome. When there are so many different communities we're serving, what's driving the inequity? Is it race? Is it deprivation? Is it something else? It allows us to track changes over time, so we know if the changes were made an improvement. And if they're working, we can scale them up. If they're not, we can try something else. And it also allows us to compare across organizations or geographies. And this is really powerful for learning, and why we're really keen and we're delighted to be invited today, because we'd like other people to adapt we hope adopt this and share, and we can then learn together and compare different outcomes. And if you're getting a more equitable outcome in an area than we are, we'd like to know how, so we can adopt that and learn together. Next slide, please. It also links to central NHS strategies and approaches we've all adopted, particularly Core 20+5. And so central to it is it always considers the Index of Multiple Deprivation in its calculations. And you'll see that in a second. It includes plus characteristics. Pippa set out the context in Northwest London. For us, with over 200 different ethnicities, race is central to that, so that's why we put that there. But the principle would allow you to focus on age or sex or other characteristics depending on your local context. And as we've gone and looked at some of the focus metrics, we've started to pilot this and use this with. We've focused it on the 5 areas, including areas like COPD admissions and under 10 tooth extraction. Next slide, please. Piers is going to take you through in a second about how it's calculated. So next slide, please. But where we've started, we built and looked at the other dimension, the 5 dimensions or 6 dimensions of quality. We use the IHI definition. We adopted that looks at safe, effective, patient-centered, but also timely and sustainable. And with our patient and our partner and our staff group, we prioritised a few areas in each of them that really we felt drove and impacted health inequalities and where we wanted to start applying the equity index. And we use these different 30 metrics within that quality indicator and build that into the dashboard and aggregated all of that together to give us our overall equity index as a trust, so we can see overall how we're improving, as well as where some of those priorities are within each of those dimensions. And these are some of the areas that are critical to every trust, but also reflect local context. So, for example, sickle cell patient experience scores or under 10 tooth extractions were 2 areas that really mattered in our local population, which is why we prioritised some of those outcomes. Having introduced some of the context and how we use the number, I'm going to hand over to Piers now to explain how it's calculated and some of the technicalities behind it.
Perfect. Thank you very much, James. So as James says, I'm just going to talk you through an example of how it can be applied. And so we're going to use one example of one of these 30 quality performance indicators and talk you through using dummy data. So once again, to emphasize some of the changes, just how we can calculate this. So we move to the next slide. So if we took our did not attend rate, our DNA rate for the trust, and we saw that was at 12% across all different groups and all different services, one of the first steps that we do is to disaggregate that data. So if we go to the next slide. So I've disaggregated it here into race, but equally we could be doing this for index of multiple deprivation. We could be doing it for any other characteristic, age, sex, and so on, and all aligned with the core 20 priorities. And so what you can see here is that we've got some quite big variations within this. We've got white down at the 2% DNA rate. We want that to be lower to be better. And we've got black all the way up at 18% or so. So if we go to the next slide, one of the first things that we do is define our reference group. So we identify the group that has the best performance, coloured in black here. So in this case, this is our white patients who have the lowest DNA rate. And this is the rate that we want to be getting everybody to. So we want to be really sort of referencing this highest quality outcome. If we go to the next slide. So as I mentioned, we define this as our reference group. Next slide. And the key step here then is off the back of this, we calculate the difference between all of our other characteristic groups to this reference point. If we go to the next slide. So just as a little aside here, so as with any of these metrics, there's a degree of statistical uncertainty with these averages. So we do take that into account. And so you can see here, we've got these uncertainty bars to represent how confident we are that the average is actually the real average. If we go to the next slide. So a big part of this is around using mathematical tests to actually find any differences that may not be real and are just more of a sampling error. And so you can see here there's an overlap between white and mixed, which is suggestive that actually this may not be a true difference, more of just a sampling error within the data. So what we do off the back of that is while there is a difference between the averages, we count this as 0 to make sure that we're not incorporating differences that aren't really real and are more of an aberration of the data itself. So if we move forward, so you can see we've got that 0% in here. The first step then is calculating the mean absolute deviation. And so in doing that, essentially all we do is we average out these variances between the reference group and our individual characteristic groups. If you move to the next slide, we then identify the group with the worst quality, which in this case is our Black patients who've got a DNA rate of 18%. Go to the next slide. And doing that, we scale the mean absolute deviation by this. And this is what gives us this consistent scale between 0 and 1 and what's known as the relative mean absolute deviation. It also crucially allows us to bring rates and percentages into the same units. So we can compare things, we can compare DNA rates, but we can also compare things like number of clinical incidents over a period of time and under the same units. So we move to the next slide. And so that's the technical bit behind it. And you can see this is an example of it in practice. And so this is the equity index for face-to-face DNAs. And I believe this is for our ophthalmology department. And so you can see that here we've got an equity index of 0.18. And you can see when we break this into the dashboard, which is readily available to all staff, that they can see the breakdown and how this is varying based on deprivation on the top left-hand side, age group to the top right. Oh, sorry, if we go back a slide. Yeah, sorry. Age group to the top right and ethnicity at the bottom there. And I suppose one other area to sort of highlight in this dashboard as well is in the bottom left box, you can see we've also got demographic data completeness. And this is a side piece around actually we want to maximize that. So you can see here in ethnicity, we've got around about 72% completion. So one of the side aims of this is about bringing those data completeness elements as high to 100% as possible. We've been doing some extensive work around that. So
just a couple more minutes, Piers.
If we go to the next slide. So the equity index itself is just a tool. And so it needs to actually fit into governance processes and work processes. And we do that through our equity program. And I believe Dr. Natusan Gupta is on the call, who expertly chairs the group. And the program itself aligns with the core 20+5 and has a variety of different pillars around data quality, processes, conviction and anchor, as well as partnerships. If we go to the next slide. And how we've used the equity index. So when we're defining our local core 20 or local plus groups, we've used the equity index to help this prioritization process here. So you can see on the y-axis, we've got the equity index, but we've also got on the x-axis around our ability to influence any inequity. And this allows us to choose the areas of local focus that have the highest levels in equity, but also we have the highest level of influence over and prioritize those in our program. If we go to the next slide, you saw in the snapshot of the dashboard that was ophthalmology DNAs, and we see some high levels of inequity around deprivation and ethnicity. And so this is a focused intervention that we put in place to help reduce those inequities. So we're working with Brent Carers Centre, so a local carers voluntary organisation, and we've set up a volunteering call bank, and we are proactively aiming our DNA calls and follow-up calls before appointments at patients from the most deprived areas. And so they'll call them, remind them of their appointment, and then they'll feed back to us. And we've seen some really positive changes in our DNA rates off the back of that in the most deprived areas. So if we go to the next slide, and I think I'm handing back to Pippa here to close.
Thank you. So it gives you a bit of an over summary of some of the work that we've been doing. But, all of this contributes towards the goal of becoming an equitable and anti-racist organisation. I won't read it out, but here is our anti-racist statement. We were one of the first to publish one. It was very important to our staff that we did. We've been very vocal about publishing it, and we've got a implementation plan of how we will achieve that as well. for us, this anti-racist statement is not just about staff, it's our population that we're providing care for as well. And it's really important we play this over the patient as well as a workforce perspective. And that's exactly what some of this work's allowed us to do. So happy to take any questions.
Fab. Thank you, Pippa, Piers, and James for that. I'm going to open up the Q&A now. If you've got a question that you want to ask, please do raise your hand, and say who you are and where you're from, and then your question. So I think I've got Olivia.
Hi, thank you. Fantastic presentation and such powerful, thought-provoking work. Definitely want to nick that. I'm new into Oxford, but I used to work in London. I miss it a bit complex. I was just wondering about the first point of data capture. Whether that's at primary care and or sort of support for ward clerks, and how we really get that, talking to our smoking cessation people, and the difference between what we expect from the wider population versus what we actually get captured or reported in hospital was quite a stark difference. So I just wondered whether you've got any sort of thoughts or tips around that. Thank you.
Do you want to answer that, James, because you've done a lot of work in the data capture?
I'm just getting off mute. Firstly, just looking at some of the data makes a big difference. And so we had an example of one of our services which wasn't on our core patient record. We did this with, and it revealed it hadn't been captured. It wasn't part of the structured information, but we're able to then match with NHS numbers on the rest to improve the richness, and looking at regularly helped. We've also worked with partners, and there's been some really clever stuff that I can't explain properly, but using robotic process automation, accessing the NHS spine, accessing information like the whole systems integrated care dashboard, which is a North West London integrated care data set that has allowed us to improve that. And that's updated our patient records, so we have that information. One of the areas I'd love to get to, and we haven't really done enough of yet, is the same as when you perhaps call a call centre and they ask, can I just check some of the details? And so having some of that within our workflow to make it more normalised, also through the NHS app will be another area. So when patients are waiting, or encouraging them to fill that in, just to keep that richness and that integration up, because the more accurate we have that information, the better these insights would be.
Thanks. And thanks for that. Claudia, question from you.
Hi, good morning. Yes, likewise, like Saffron said, brilliant presentation. I think a question for me. So I'm for the Northwest Ambulance Service, and this is we are the National Association of Chief Executives is promoting us, encouraging us to do more for reducing health inequalities. And yes, the principles that Saffron mentioned at the beginning, we're trying to incorporate. So the question for me is about capacity and capability. So what are your suggestions on the kind of training program that you need to provide to staff to enable them to do this kind of analysis? And likewise, you have that support from the board. How can you enable your board members to support this work and lead it? Because getting your head around the data, it can be quite tricky. So what is your suggestions for training that we could provide across the trust to enable this?
Piers, do you want to talk about the support we've given staff to use it?
Yes, I can. So the way we've built it is we that 0 to 1 element has been quite crucial to it. So trying to simplify it down to 0 is good, 1 is bad. And the way we built the dashboards is any member of staff can access it. I've just answered a question around that. So it's completely self-serve, and they can go to as much detail as they please. So they can see the high-level number, and they can see that for their service. They can delve down if they want to into the graphs and those kind of things if they're so inclined. And so we've tried to build it in a way that is relatively intuitive, and we've built a whole lot of information pieces around that. As well as that, we've been doing a variety of roadshows and the likes of things to introduce it. And so it's been a combination of building it a way that it is user-centered and can help understanding of it. and then also some active sort of going out and training people on how to use the tool itself.
Thank you. Any suggestions on the training on how do you develop that?
So we have engaged with some members of the team to understand, so when we were actually building the tool itself, to understand where some of the pain points were when it came to some of the information. So some of it is around the statistics, and actually we have exposed some of that, and that can, it's a good and bad side of things, as it can push some people away. And so some of the focus there is actually around more generally as a strategy program, how we improve the numeracy and the understanding of data in the trust as a whole. And coming in next year, we're building our education strategy, which a big component of that is around digital literacy and numeracy. And so there are some basics off the back of that, but also pointing some of the people to some of the things that are out there already. Microsoft has a variety of training packages around numeracy and data literacy and the likes of things. And so it's building on some of the more basic training that we're doing, and then offering this as an adjunct, and going through our improvement networks and getting working with the willing to empower and champion this tool.
Thank you very much.
Thank you. I'm going to take a question from Daniel, and then I'm going to ask a couple of the questions from the chat. So Daniel.
Thanks, Saffron. Good morning. My name's Daniel. I am the Strategy Development Manager at Hertfordshire Partnership NHS Foundation Trust. We're a mental health organisation. Just really want to thank you, Piers, Pippa, and James for the excellent presentation. You've done extensive work within your area around really trying to understand equity from a data standpoint. I've got a question and a request, if that's okay. So the question is, your data quality score for ethnicity is around 77%. And I guess, how have you been able to circumvent the challenge around having the confidence to interpret that data in a meaningful way and being able to use that to implement change? And then my request is, if it's possible, Piers, would I be able to connect with you afterwards? I'm really keen to learn from the work you've done around the equity index score and how we can actually implement that in Hertfordshire. Thank you.
Shall I come in on that point? Or?
Yeah, I think really interestingly, one of the questions from the chat was basically, how can others use and reproduce this tool? So perhaps those two nicely come together.
Perfect. I'll take them one by one. So the first is around the ethnicity side of things. So it's a bit of a chicken and egg sort of piece, in that we wanted to, we didn't want to hold off from doing this analysis. And so really making that data quality piece quite clear in each of the dashboards has been important. And as we improve that, we may see some changes. And a big focus for this year is really setting the baseline around the equity index and working on that data quality beneath it, starting to expose these things and make it more visible. And as James mentioned, we've already done some really great work. We're very lucky in Northwest London to have whole systems integrated care data. And so we're actually patching in information from social and primary care into our patient record to start to fill that up. So what I'm told is when we next run it, we'll hopefully see quite a big jump in that, yet to see what that jump is in itself. But there are some areas where we know that, the data quality is worse than 77%. And so we have to put a big sort of question mark over that. But that shouldn't stop us highlighting it and doing that analysis and really making it clear. So some of this is around the visibility of it, not shying for it. Yes, the conclusions may change as that data quality improves, but that's sort of one of the side aims around. So I hope that answers the question in itself. And then in terms of more generally sharing it, so we've had quite a lot of people reaching out interested around how we can actually do it, and we're very happy to share the methodology. And we've actually written out the methodology, so we're very happy to share that around. And we're exploring at the moment writing into a publication as well. And we've built this in ClickSense, which is our local way of doing things. That's not the case for every single one, but equally our analyst is very happy to share any code aligned with that if providers or ICBs are on the same dashboarding software.
Thanks, Piers. just in the interest of time, I'm going to draw this Q&A to a close. There are loads of questions in the chat. James, you've been really helpfully answering some of them as we've been going through, and thank you for that. Pippa, Piers, James, it was a great presentation and a great discussion, and just amazing work that you've been doing. So thank you so much. I hope you can hang around for the rest of the session, because we might come back to some collective Q&A at the end if we have a bit of time. However, I'm going to now take us on to the next presenters, and we've got the next case study from Calderdale and Huddersfield with Claudia de Vries and Rachel Westbourne, and they're going to give us an overview of their health inequalities data dashboard, what it is, what it contains, and how they use it as an organisation. So over to you, Claudia and Rachel.
Thanks very much, Saffron. So hi everyone, I'm Rachel Westbourne. I am Public Health Lead at Calderdale and Huddersfield Foundation Trust.
And hi, I'm Claudia de Vries. I'm the Project Manager for Health Inequalities at Calderdale and Huddersfield Foundation Trust.
So the Trust has undertaken a really large programme of work to try and understand and take action on health inequalities, and we're specifically going to talk to you today about the role that data and dashboards have had in that, and the journey that we've been on in terms of using data to understand and address inequalities. And we'll give a few examples of pieces of work that demonstrate that. But just for a little bit of context, Calderdale and Huddersfield is a large acute provider. We operate across 2 hospital sites and also provide community services as well. And we're serving a really diverse population of around 440,000 people, about 14% from an ethnic minority population. And we know that 26% of our local population are from IMD areas 1 and 2. So we do have an overrepresentation of the most deprived communities in our patch. And we see that showing up in health inequalities too. There are significant inequalities in life expectancy locally between our different population groups. So that's just a little bit of background to us as a trust and the communities that we're serving. Can I have the next slide, please? So we're going to take you through a few little examples of pieces of work that we've done. And looking at the timeline here, that's going to include where a lot of this work using data started for us, with a real focus on learning disabilities and then understanding inequalities during the COVID-19 pandemic, and particularly the elective recovery period following that. How we then built on that work and solidified it, including through producing our health inequality strategy, where one of the key priorities is around equitable access, and all of the health inequality strategy work is underpinned by using data and intelligence as a key way of working. And then we're going to talk about some of our most recent work and our ambitions for what happens next. And that's around how we've been trying to use data to proactively identify patients at greatest risk and do something differently for them to prevent inequalities happening in the first place. Next slide, please.
So like Rachel explained, it's not been an overnight process, and this is something that we've really had to work on back from 2010. So we've really had to have that data-driven approach, and it did start with learning disabilities. This started with us developing a tool to identify those with a learning disability. And this was so we could understand their experiences and monitoring our differences that we made. So it started with the flagging system within the patient record. And then this then allowed us to build the learning disability data dashboard. This then produced our data models where we could compare data from learning disability patients and compare that with the general population to really see if there was any differences there. We then ran a few deep dives into the full patient journey from referral to treatment, and this led to further audits on things like reasonable adjustments, cancer data, missed appointments, and allowed us to look at information as well on readmissions, length of stay, and mortality. So we were really focusing on following that patient through the whole journey, understanding where our sticking areas were, and then where we needed to target any improvements. Next slide, please. So this is an example of our learning disability dashboard. It shows live data so staff can see where and when patients with learning disabilities are in the hospital. And if anyone can see, I know it's really small, but it shows things like inpatients, outpatients, length of stay, there's missed appointments and ED attendances as well. Next slide, please. So this is an example of another one of our dashboards. This is one of our accessible dashboards. So we built this with self-advocates and people with lived experience. At the time, our data was reported into our learning disability task and finish group, and the people in that meeting with learning disabilities just told us that they did not understand our dashboards. So we put together some workshops to look at things like the font size we were using, the colours and the graphs which they liked. And this is something which, we're really proud of and that we co-produced with them. So as you can see at the top there, there is a difference in the 4-hour target for patients with learning disabilities compared to the general population. And this has been quite consistent. But when we have looked into this, it is because patients with learning disabilities usually require a side room. They need things like reasonable adjustments. They could need a capacity assessment. And we also found that they usually present later in ED. So therefore, there's a greater chance of them needing an admission than somebody from the general population. So sometimes by creating this bespoke pathway to meet the needs and get it right for the patients, it did mean that we sometimes don't meet that target. And we absolutely will not be hitting a number or a target before putting the patient experience first. So just to summarise on that, excuse me, the Equality Act means the same outcome and not the same service. Next slide, please. So this is an example or a graph showing our patient weights for people with learning disabilities and compared to the general population. So back in 21, when we decided as a trust to prioritise patients with learning disabilities, you can see that consistently reduced the wait time to be less than the general population. Until quite recently, where you can see the big red arrow, we did see a spike in this increase. And the data from this dashboard has since been shared with operational teams. And I know it was built into action plans to bring this back down again. So you can see that it's decreasing again and it has remained that way. So I guess this is just an example of how we've proactively used our data, not just to monitor, but to also sustain positive changes that we've made. Next slide, please.
So the LD work was really foundational in establishing that we would take a data-driven approach to understanding and addressing health inequalities. And then I think the other piece of work which was really key for us was the work done during the COVID and elective recovery period to understand inequalities in waiting times that would be occurring as the backlog was growing. This built on work during COVID where a dashboard was built to show the state of the hospital. It became really important to get a really good sense of what was going on as we were dealing with COVID. So a live COVID model was created to show hospital activity, things like the number of COVID patients we had in and where they were, discharges happening on any given day, and bed availability as well. And we were then able to, having this existing model, build on it to start to look at all that activity data through an inequalities lens, splitting the data by things like ethnicity and IMD. From there, we were then able to create a health inequalities dashboard, so we could share that information in real time with specialties and clinicians and operational managers, which enabled proactive monitoring and targeting of inequalities that we might see emerging. And to give an example of what that looked like, when we did analyse our waiting list data through this inequalities lens, we saw that some groups were experiencing significant inequalities in terms of how long they were waiting for their care. So for priority 2 ethnic minority patients, for instance, back in March 2021, we found that they were waiting for 7.2 weeks longer compared to their white counterparts. But then thanks to the proactive monitoring and the action that was taken as a result of that to get the backlog down and to target particular patients, this then reduced to a wait of actually 0.2 weeks less than white patients by March 2022. We saw a similar inequality for people living in the most deprived communities as well. So when we looked at priority IMD 1 and 2 patients, they were waiting at the height of waiting times 8.5 weeks longer than patients from the least deprived deciles, IMD 9 and 10. But again, over the course of a year, we saw that reduce to them waiting just 0.4 weeks longer. And these are metrics that we continue to monitor as well, so that we can respond quickly if we note an inequality starting to emerge again. Next slide, please.
So the Trust has committed to the continuous monitoring of health inequalities, and we now use our data and dashboards to populate this IPR report. So this is used to provide clear monitoring and reporting to the Health Inequalities Group and also our exec board on a quarterly basis. It provides performance monitoring on ED for our targets, missed appointments, diagnostic weights, cancer diagnostics, and also 40-week weights as well. And you can see it includes patients with learning disabilities, areas of deprivation, as well as ethnicity. And it allows us to monitor health disparities and then action any audits if there is a difference or any health inequalities there. Next slide, please.
So that's work that's been undertaken to allow us to understand and monitor health inequalities that we might see emerging in our services. But what we've been trying to do more recently is go one step further in terms of taking a patient-centred approach and using the data that we have to identify people who might be at the greatest risk of experiencing inequalities and doing something about that, ideally before they actually experience the inequalities in the first place. So we've developed something that we call the inequality flag, powered by our inequalities matrix. And the idea behind this was to enable us to take a more holistic approach to prioritisation and care, recognising, as we'd seen really starkly during the COVID period and for our patients with a learning disability as well, that people have really different experiences and health outcomes due to a range of broader risk factors and socioeconomic circumstances. And so we see this as being part of our priority to address inequalities and particularly barriers to access as well. So as I say, this began with something that we call the inequalities matrix, where we tried to combine different data points to understand which patients might be at the greatest risk of experiencing inequalities and poor health outcomes. So we were looking at our data to understand who is most likely to experience inequalities, and also looking to national evidence too, to understand what are the biggest risk factors for someone potentially experiencing inequalities, and seeing how we could marry that up with our data to identify who might be at greatest risk. The way that the matrix and flag then works is that each patient is given a score to indicate how vulnerable they might be to experiencing inequalities. And from there, we create the flag to identify patients who have got the highest scores. At the moment, we've set that threshold to the top 20%. So the top patients who have a score that falls within the highest 20% of scores across the trust are given a flag to indicate that they may be particularly vulnerable or high risk, but that threshold is movable. We might decide that we want to focus on the top 5%, 10%, or vary it depending on the area or specialty that we're looking at. But that's where we have that set to for now. And I think the most important thing about the flag is that it can be easily incorporated into our existing operational dashboards. So rather than necessarily asking people to go into the matrix as a separate thing and look at all the detail that sits there, instead we've got something that works with existing systems and will just highlight patients who are at the greatest risk. So we were trying to make it much more user-friendly so that we could really operationalize it. Next slide, please. So just to go into a little bit more detail about how the flag actually works and how the score is calculated, we start with firstly what we call the core indicators that are included in the matrix. And these are those factors that we know are the biggest influencers on how likely someone is to experience health inequalities. So we have in there deprivation, defined by someone's IMD decile taken from their postcode, learning disability status, ethnicity, and whether someone is no fixed abode, because we know that that will make people particularly vulnerable. Each of these indicators is given a weight of 1 when they're put into the calculation to give the vulnerability score. Next slide, please. But then we also have the ability to include additional indicators as well, and we give these a weighting of 0.5 when they go into the score. So this could include things like record of admissions for mental health or admissions related to drugs and alcohol misuse, smoking, whether someone is a high intensity user. We can look at whether someone has had a certain number of emergency attendances or unplanned admissions over recent months, English as a second language, unpaid carers, and access to health hazards and assets and hazards, which, if people aren't aware, similar to IMD, this is a measure that, based on where someone lives, looks at what their either access to health assets, health promoting things is like, or what their exposure to health hazards is like. So again, trying to give us a more holistic view of patients and what risks they might be experiencing. Next slide, please. So the flag identifies patients who we think are at the greatest risk of experiencing health inequalities, and then we hope that it can be used to help us do these 4 things. Firstly, as I've said, identify the most vulnerable patients and have an understanding of how many patients within our trust have an inequality flag and how that varies potentially by different waiting lists and by specialty. To understand what it might be that these patients are experiencing, so we can look at key performance metrics by the inequality flag and see if that group are having a different experience to the rest of our patients. Is there delayed access to care, longer waiting times, or worse health outcomes? Ultimately, wanting to use the flag to reduce any existing inequalities that we do find. So if we note that there are higher waiting times or DNAs for this group, then doing something different about it, and preventing future inequalities by having plans in place for what we might do differently for patients who do have an inequality flag, recognising that they might need a different kind of booking process or enhanced support while they're waiting for care, perhaps. Next slide, please.
Just a couple more minutes.
Okay, thank you. So the flag can be pulled into various existing data models so that individual teams can identify their most vulnerable patients. And just to give some examples of things that we've been starting to look at, waiting time inequalities and DNAs, as I've mentioned, patient outcomes, and also the potential for targeting particular interventions. And we've started working with some particular areas to explore how it might be used, and that's include cancer rehabilitation services, the appointment centre, particularly on DNAs, outpatient waiting lists, and maternity psychology and paediatrics. We've all built inequality matrices for them so they can understand their patients and what they're experiencing a little bit better. Next slide, please.
So this is an example of our maternity dashboard and how the flag kind of operates there. So it shows things like stillbirths, miscarriages, low birth weights, poor birth outcomes, and women who accessed care before or after 13 weeks. And this dashboard allows us to look at these measures and identify who in that population of women is vulnerable or may need additional support accessing care. Next slide, please. So what this told us was significant percentage of poorer outcomes were from the most vulnerable population. So 42% of our stillbirths were from vulnerable women, 38% of our miscarriages, and only 77% of women with a flag accessed maternal care before 13 weeks in comparison to 87.5% for all other women. And how we're using this to reduce inequalities is currently looking at data to inform the decisions around targeted interventions for these women. So like Rachel said, that could be an extra appointment, it could be a phone call, but just simple things to really improve the access to care. Next slide, please. And another way in which we've used our data to look at inequalities has been in an area where we consistently see that unfair disparity. So I'm sure we're not alone, but this is missed appointments. And to try and reduce this disparity, we have conducted a pilot with our appointment centre, which offered an intervention to improve their access to care. So the targeted patients at the time were IMD 1 and 2, who were at high risk of missing an appointment. And the intervention involved the appointment centre calling patients to book an appointment, which gave the patient an increased choice of time and date which suited them, and this increased accessibility and flexibility. And it's probably just worth saying our standard process was just to kind of send a randomly allocated appointment in the best hope that the patient could make it, and if they didn't attend, then our rebook process was exactly the same, to do the same again and hope they can make it. So we just really wanted to see if by changing that booking process, would that make a difference. And the intervention did produce a 5% point reduction in DNA rate for the targeted group. So we are looking to expand this work now and really incorporate the use of the inequalities flag within that. Next slide, please.
So just to sum up, I think we've really found that data and intelligence can provide a really powerful tool for understanding and addressing inequalities, and that data is needed to underpin really understanding how inequalities might show up within our services and then guiding you as towards how to really address that. But a few caveats to that, I think, and learning that we've had, it does require high quality data and the right systems. Essentially, you need complete, timely and good quality data in order to really do this work well. We're very lucky. I know that our ethnicity data, for instance, is near to complete, and if it wasn't for that, we probably wouldn't have been able to undertake some of the work and analysis that we have done. We've really found that it has to be presented in an accessible way, and we've seen that with, for instance, the IPR report. We've created quite simple visual reports that focus on a few key indicators because we found that that's easier for people to engage with and to understand. And really, the key bit of all this is that it should drive action and improvements. So it's great to have really brilliant data analysis and some nice dashboards, but ultimately this should be about, okay, what happens after that then? We've seen this inequality, but what are we going to do about it? So the data really has to be a tool to drive improvements and to guide us towards particular actions. And then finally, just a few points which are essentially around the difference between numbers and understanding. So data might show us one thing, but that's not the entire story. And as Claudia said earlier, what we will never do is chase the target but miss the point. Numbers might indicate that there's a problem, such as an increased waiting time in ED departments for patients with a learning disability. But we then really have to dig into that to actually understand what's happening in terms of the patient experience and make sure that it's the patient experience that's at the forefront of what we do, because it could mean that, as Claudia outlined earlier, there might be a discrepancy, but there could be a particularly good reason for that. And if we want to kind of take any action to address the inequality in the numbers, we have to really understand what's happening first. And I think finally, just for us, that idea of equality compared to equity underpins a lot of the work as well. So we're not just thinking about, are we seeing equal numbers in the data, but actually, are we delivering an equitable service that is proportionate to people's needs, recognising that patients have very different needs and will require different care, regardless of whether or not that necessarily shows up in the data. And that's everything. Thank you very much, everyone.
Thank you, Rachel and Claudia, so much. Really, another really fascinating presentation, really giving us that detailed walkthrough of what you've done and how you've done it and how you're really making an impact as well. Okay, I'm going to see if there are any questions from anyone on the call. Anyone want to put their hand up and ask a question? Where are we? Can't see any hands on this one. I think I've got a fundamental question on this that I want to ask you, which is around why you chose to focus on learning disabilities as a key indicator to start with. That's just, I think, really interesting. It's come through from your presentation.
At the time, our chief exec, Owen Williams, had been to a conference in London, and it was just after the pandemic, and it just really highlighted the disparities in outcomes for this population. We also have Amanda Mackay, our consultant nurse for learning disabilities, who hugely advocates for people with learning disabilities. So yeah, that was the initial reasoning with starting with that population.
I think it was part of recognising that we know as a group they do face really significant inequalities. Life expectancy can be up to 20 years younger for people with a learning disability, and we knew from reports about that premature mortality that a lot of that was around preventable mortality and delayed access to care and having really subpar experiences of care as well. So it was a population that felt really important to do something different for. And as Claudia said, we were very lucky in the trust that there were some key people who were really passionate about, committed to and knowledgeable about that work, so could drive it forwards.
I think as well that population is very complex, and so I mean we say it all the time, if we can get it right for somebody with a learning disability, you should be able to get right for everybody, because the bespoke pathways that this population sometimes require are very, very complex.
Thanks. I'm going to bring Pippa in. You've got a question.
Thanks both. Fantastic presentation. I'm just texting Piers and James to say I want this now. So, they're going to be busy for the next few weeks, aren't they? So the maternity dashboard, I think, is really quite powerful and really plays to a lot of the inequalities work nationally that's happening around maternity. Have you had it long enough to be able to evidence that it has reduced stillbirth rates and improved maternity outcomes? Or is it too soon to tell?
We haven't. It's very new. I mean, I would love to get to a stage where, we'll be analysing all of that. But no, it's very new. I'd say a month, Rachel, a couple of months at most. We've had it up and running. So, we're really still unpicking all of the detail from that.
It's really exciting, though. I'll be watching carefully. And James and Piers will be in contact.
Great. Okay, I'm going to go to Neetu next.
Oh, hi. Sorry, I'm from the same trust as Pippa, Piers and James. Really, really interesting data. My question is more about system improvement. So you've raised the issue about learning disabilities. So a lot of the work that you're doing or that we're doing are trust specific, and we want to make sure that the system, so learning disability, for example, I'm a consultant community pediatrician. Children and the coding of learning disability in primary care doesn't necessarily feed in to our hospital or community providers. So is there a bit of work that you're doing? You're identifying learning disability codes. Is that how, are you feeding that back to primary care? Or are you feeding that back to other trusts that might be looking after the same patients? Thank you.
So our flag was initially built from the GP registers, and I mean, don't quote me on the date, I'm sure it was in 2013, I want to say, and that was recently done again the start of this year. So it's something that, we do work with GPs on, but I know it took a while this time around to kind of get the sharing agreement and things in place. So it depends if you've got a good IG team, but I know that it's very much working with the GPs on that flagging system.
Hashim.
Hi, all afternoon. Yeah, my name's Hashim. I'm a senior policy advisor on population health at the NHS Confederation. Very similar question to Neetu, actually, in terms of I was going to ask around whether the flag or any of this work has kind of been sort of utilized within sort of kind of primary care or even sort of community care to sort of kind of really allow them to do similar sort of kind of analysis and sort of implementation. And it seems like you're kind of with the learning disabilities piece, but I was just thinking wider in terms of kind of addressing inequalities in sort of kind of clinical management of other conditions, CVD as an example.
I think more broadly, we're kind of just starting to really operationalise the flag, but we are looking at how we can share it with local authority and community partners as well. So one piece of work includes how we might target patients for waiting well initiatives. So one of our local authority areas has got Core 20+5 funding to deliver some additional waiting well support. And they asked us as a trust, is there anything that we can do to help them identify those populations that might benefit most? So we're using the inequality matrix and flag to find communities that we think might most benefit from those targeted interventions. And similarly, this wasn't the inequality matrix, but we have tried other pieces of work where we use our data to try to help primary care partners understand what might be happening at their end. So we had a primary care network who noted that they had a really high number of patients with chronic respiratory conditions and potentially poorly managed asthma. So they approached us as a trust to see if that was something that was showing up in our data as well. So we were able to look at our admissions data for that PCN area and see if there are any differences in unplanned admissions or ED attendances related to respiratory conditions for that population. And we did note some inequalities. And that then led to a working group that was established for about 18 months to try and take some targeted work to improve communication pathways between primary and secondary care, for potentially highlighting patients at increased risk of respiratory exacerbation. And then some work with public health as well to offer some more fuel efficiency support and home improvements to those patients who might really benefit. So I would say we would really like to do more of that. We've had a couple of examples where it's worked nicely, and we would really like to do it some more.
Thanks. That was a really comprehensive answer. Thank you. Can I just pick up on some of the questions that we've had in the chat, and particularly struck by the question around whether patients who've been involved are actually aware that they've been flagged by the tool and what that might mean to them, just in terms of how that works practically.
So we've not yet done anything differently with patients who have got an inequality flag. I think the closest we've had to this is patients in IMD groups 1 and 2 who were identified at high risk of being a DNA, being offered something different through the pilot. And Claudia, they weren't informed of that, were they?
No, but I was going to say patients with learning disability are usually told that they do have a flag, and it's a mix really. I mean, some come forward and say, I don't want to be flagged, but when you explained, why they've got that flag and the outcomes, and usually if you say that they get to be seen by Amanda, they're sold and happy that they get to see Amanda and be treated by her. So I think, very, very mixed feedback on it really, but I guess from our point of view, it is just to better that patient care and outcomes. So I think once you do embed that message, that they're quite happy with that.
It's a really interesting question, though, and I think it's something for us to kind of think about and maybe take into a patient engagement space to get a better understanding of how do patients feel about us doing this kind of work.
I think it don't want to overcomplicate it, but it has potential ethical impacts, doesn't it, really, in terms of kind of handling that. So it is an interesting point. And just some of the other questions that have come up, which is how you're collecting the data for some of the indicators in the matrix. So what's your data collection approach?
So the indicators that are in the matrix are data that we already routinely collect as a trust. Like IMD obviously comes from patient postcode. Ethnicity, we're very lucky that is really well recorded for us. It's actually a very complete indicator. There are other things such as Claudia will know, getting complete learning disability data and getting that built into patient records, I think was a significant challenge. And there are probably other areas like that too. But a lot of it is data that we already know that we have, and then we look at the completeness to see if we think that it's kind of high quality enough for us to put it into the matrix.
And just to elaborate on that, it's a constant work, because I mean, with learning disabilities, for example, when we did realign the registers quite recently, you find that people have passed since, and so that's not been updated, and things like especially our additional indicators like smoking status, that can change, and so we're really relying on our workforce updating that when they have that contact with the patient.
Thank you. I'm just going to do a last call for questions from the floor, the virtual floor, you know what I mean, the audience, participants, not looking like anything there. So one final question from me, which is, hold on, there's a question coming up. Is in terms of the challenges you've faced in using the data, because I think you've actually from both presentations you kind of set out a process now which looks pretty seamless in terms of how you've done it. But just think about some of the challenges you faced in using the data to understand the inequalities and then how you overcame that.
I think, to be honest, the biggest challenge isn't in understanding the inequalities, it's in doing something about it.
Okay. Yeah.
I think once you've got the right data in place and you've got the systems and the technology to be able to cut your data through various lenses, whether that's IMD or ethnicity, etc., and you kind of get a good sense of what indicators you want to look at, whether that's waiting times, outcomes, etc. Then understanding the inequalities isn't too much of a challenge. You will kind of see them, but actually digging into it to understand what's going on, what's causing them, and what's our role as a trust and a care provider in doing something to address it. What levers do we actually have to pull on to change that? And then getting the capacity, the resource, the willpower, and commitment in place to do something. I think that's more of a challenge.
Thank you. That's really helpful. Okay, we are nearing time. Claudia, I see you've got your hand up, and then I'm going to ask all of the speakers if they want to just say any final words. Claudia, you're on mute.
Should we find that?
Yeah.
Yes. Thanks for the presentation. My question is in relation to how you combine the knowledge you have developed in health inequalities and the data with a quality improvement approach. Because at the moment, sometimes seems to be two different kind of schools of improvement. So are you linking with your quality improvement group at the trust to embed that focus on health inequalities in the work as well?
Good question. Which of you wants to answer that?
If I can start, if you don't mind, Saffron, because I think it's a very relevant question about we are constantly churning out the data and identifying, but the so whats are not always completed. And that can lead to a frustrating cycle of just identifying problems but not doing anything. And I think that's what we've heard. But I think what our equity index is enabling a lot of on the floor frontline clinicians to see effects of interventions. And there's a lot of work streams across organizations that we are cross-pollinating. So this is not duplicating work that's already been implemented across. I think what we have to do as leaders is sometimes block or give permission to prioritize certain work streams, and we give the tools and we give the support and we look at it at regular intervals to see how we've progressed. And I think empowering and enabling that has been crucial in our sort of equity group. And it's been really, really inspiring to see how many people have just come on because they are so motivated to do something about health inequalities. And that is where I find Piers and James's tool has really empowered many people to do something about things that they've known for a long time and then see if that is making a change. So in our organization, I'm really feeling quite enthusiastic that we might progress to results rather than keep identifying the issues. I don't know if anyone else wants to back that up, but I feel very optimistic at the moment.
Super. Any other final thoughts from Piers, James, Claudia, Rachel?
I'll just jump in. So I really, Rachel and Claudia, fantastic work. And I think there's a really nice complement between the two presentations today. I recognize our equity index looks at a problem very much top down. and then allows you to sort of explore in the what you could do and then test what's happening. I was really impressed with the flags, particularly about how you can think about the impacts on individuals and how it might prompt differences. And then the complement between them about whether you can see that then make a difference. And if it is, then how you go and do more of it. The question before about some of the challenges, and it echoes a bit about what Nita's just shared. This does take some clever people working in our analytics, our BI's team, some time to focus on it. And when the ask is around activity and coding and recovery and all the other things that are absolutely right to focus on, it is making sure they're prioritised and supported to spend time on this. And that's been part of our strategic shift, where we've been able to find someone who's been very good at doing this because it's been central to our organisation. But I think there's how do we find it inside our organisations, and then how are there tools like the Federated Data Platform and others that could incorporate some of this right from the off. As an example, if you're to look at standardised hospital mortality index, it doesn't include race as one of the characteristics you can look at in terms of driving differences. So some of the tools, and I hope NHS providers and others, that's for national policy, can think about how this could be incorporated in some of this shared analytics that's done nationally as well.
Thank you. That's really helpful. Claudia or Rachel, can I?
I think the last thing I would mention is just that we are incredibly lucky that we have a brilliant health informatics team and service, and so much of this work would not have been possible without them. There's some really dedicated people who fully support us with this, and me and Claudia wouldn't be able to do what we do if it wasn't for the work of the health informatics service and the fact that we have those people and those systems available to us. So it really is key and important.
I think as well, you've just got to be relentless. I mean, we had a conversation quite recently, me and Rachel, that it's just that consistent message kind of to everybody. We do struggle with engagement, especially from our clinical side, and kind of getting them on board to do something different out of the standard process is sometimes very, very challenging, especially when resources already spread very, very thin across the NHS, and there's not a pot of money to do it. So it can be a great challenge, but I think, you know, me and Rachel are thankfully very passionate about this, and hopefully we relay that message in a positive way and make it really meaningful to whoever is our audience, so they want to do something about it rather than us forcing the hand.
Thank you. That's fab. Okay, I'm going to bring this to a close now. I do just want to thank all of our speakers and thank them for presenting to us today and for the work that they're doing. So Claudia, Rachel, James, Piers, Pippa, really fantastic work, and thank you so much for that. And I just want to reflect that it's been some I think we've just heard some great presentations today. What comes to mind for me is that to make a genuinely strategic impact, you need to do that crunchy, granular work. There are no shortcuts in this, as far as I can tell. I was slightly terrified when the first presentation said getting the EPR together had taken 15 years, and then the second presentation had been on nearly a 15-year journey from the beginning of their work on learning disabilities. So there's something there about the length of time it takes. But I think what webinars like today are about is actually how we speed up that learning and learn from each other, so that perhaps not everyone is on such a long trajectory and curve. And the other thing that really struck me also was that this really brings Core 20+5 to life as well. Both of you talk about how that's embedded in different ways, and that feels really, really important. And I think it was Claudia who talked about the need to be relentless, and I think that's what this work is about, a relentless focus on tackling health inequalities and a relentless focus on the data. So loads to do, but some really great examples there. I'm going to draw this to a close now, and I hope that you found today useful. Please do fill out the evaluation, which is just here on your screen now, the QR code. We'll be sending round the recording. We'll be sending round the presentations so that you get the opportunity to reflect on them, review them, share them with colleagues. But thank you so much for joining today, and thank you again to our speakers. And thanks for the team at NHS Providers for all of their work.
Thank you.